to start out the day talking about hip replacements and hip arthritis and some of the new things we do for hip arthritis. So advances in hip arthritis and hip fractures. So conservative care, you come to the office and you have hip pain. Hip pain, when I think about hip pain, is three different things. So you could have groin pain, and groin pain is truly your joint. That's the ball and socket joint. You could have lateral pain going down the side of your leg. That could be coming from the joint or coming from your back. And then you could have buttocks or posterior hip pain, and that's usually from the back or from muscle spasms. So three different places you call the offices to have hip pain. Could be any of those three, and then we'll sort them out when we see you in the office. If it's truly arthritis or truly groin pain or lateral pain, then there's a few things we can do for it. We can start out pretty easy. We start out with cortisone, what we can do called PRP, which is platelet-rich plasma. That's taking your blood, spinning it down, and putting it back in. We can do the new injections called stem cells, and we can do what's called viscosupplementation. Viscosupplementation is the chicken shots you hear about. So the chicken shots are approved for the knee. They're not approved for the hip yet. We can do them, but the insurance company may make you guys pay for them. We can do therapy. We can do range of motion to maintain the motion you have. If you're losing motion because of arthritis, you can gain some back as we teach you what to do for it. We can do strengthening, so if you're getting weak and you may need a hip replacement down the road, we do what's called prehab. And Paul is out here from our therapy department. He can tell you about prehab, getting your quads stronger, your hamstrings stronger, your hip flexors stronger before you actually get into surgery. And a lot of times, if you guys get stronger and you have arthritis, you can deal with the arthritis because your strength comes back, so it buys you some time actually. And then there's modalities that therapy can do. The modalities are where they can either do ultrasound, they can do medicine, they can do what's called iontophoresis, and this takes away the inflammation that's in there. So instead of doing a shot, if you guys are afraid of shots like I am, you can do these things where they put the medicine on the outside and then use the machines to get it to go through the skin. If you're not afraid of shots, then it makes it a little easier. And then lastly, we have NSAIDs, or what we call anti-inflammatories. Anti-inflammatories could be pills, you can take them by mouth, or nowadays we have also rub-on anti-inflammatories, so they have creams and liquids that you can rub into the area and it'll seep through your skin. So a lot of things we could do before we actually get to surgery. When we do have surgery, there's types of hip surgery that we can do. So we can do what's called an arthroscopy. We put a camera in there, we look around, just like we do knee and we do shoulder, we do ankle, we can also do hip arthroscopy. We can put a shaver in there, we can clean it out. If we find a tear, we can repair it. So there are a lot of things you can do before actually you get the replacement. If it's one side of the joint that's bad, we can do a partial hip replacement. So if the ball's dying, but the socket's good, and you don't want a full hip replacement, you have a lot of tennis or pickleball or bowling that you do, and you're worried that you might be in weird positions that you might dislocate, we can just do a partial hip replacement. We can do what's called a hip resurfacing. So you're really not collapsed, it's not a horrible hip, it's not bone on bone, but there's arthritis all around the head. We can take the ball from the ball and socket and we can basically roto-root the top of it and put a little cap on it, and that cap resurfaces it. And then we can put a cup on the other side, and then you have a new joint, but you don't have any big cuts, taking a lot of bone away. And then lastly, we can do the actual hip replacement. Then the hip replacement comes in multiple different types. So we can do an anterior hip replacement depending on your body habitus and depending on your bone stock. So if you have osteopenia or osteoporosis, it's not really good for anterior hips because it could break the bone the way we put it in. If you have really big body habitus and a big pannus or big belly, it makes it hard to do the anterior hip approach because it's right there. And when you sit up, the front part of the belly will sit on the incision and it gets sweaty and moist and it can get infected, so that's dangerous. So we have done a couple where people asked us to do that, where we took a binder and we put a binder on them just to keep that belly off for a couple weeks so that the incision would heal, and then they can go on for the hip replacement part. And now you'll see as we get down the road, the person that wants the anterior hip replacement is really an active, gung-ho person. It might be their right leg, they might be home alone and they have to drive, and you can do all of your activities faster with an anterior hip replacement, especially if it's your right leg, because you can drive faster, but there are some risks to it. It's not the gold standard yet. The gold standard is still anterior, lateral, or posterior. So the anterior, lateral, or posterior approaches are where we make the incision, we peel the muscles off, and then we put the prosthesis in and we put the muscles back. Whereas the anterior approach, we just separate the muscles and drop the prosthesis through that. And we'll go over that. So the anterior approach is a straight anterior. It's right in the front of the groin, right down your thigh. It's muscle sparing, meaning we take the muscles away and then let them come back. We don't cut any of them. And it's a smaller prosthesis, so that smaller prosthesis has to sit in really good bone. We've tried it in the past where we put that prosthesis in, and if you have a little osteopenia or a little osteoporosis as you're walking, that prosthesis can subside a little. And if it subsides a half a centimeter, it's not so bad. We can do a little shoe wedge. But if it subsides a centimeter or 2 centimeters, it's really low, and then we'd have to put a bigger prosthesis in or put a cable around it. The anterior lateral approach, it comes off the anterior side of your thigh down the lateral side of your thigh, and then the posterior comes around into your buttocks. So if we do an anterior approach, this is what we have to talk about. We talk about, are we going to do it on a regular table? And some of the docs will do it on the left, which is a regular table. And some of us will do it on a special table, which I do on the right. This is called a Hanna table. And this Hanna table allows us to take your leg and put it in positions that you don't want to see, but you're asleep, so you don't have to. And by doing that, we're able to get that smaller prosthesis in, we're able to get the ball in and the socket in, and then drop the muscles back and not actually have to do a big surgery on your muscles or on your bone. The problem is, if you have weak bone and we're torquing your leg all around, we could actually break your femur. So that's important to talk about in the office when we're trying to decide, once you're ready for the surgery, which type of surgery we will do. On the left, you have to have a lot of help. And those people manipulate the leg into all those different positions, just like the table does. So when we talk about this, if we get that far in the office, we talk about the Hanna table. That's the table. That's the anterior hip table. And why a special table? We talked a little bit about it, but this is the model showing you what you can do. So we can keep this leg up. We can really hyperextend this leg and get all the way down the shaft. We can do traction down here. We can pull on it as much as we need to. We can do rotation, internal and external, with this little button. And then we can do abduction and adduction, where we take it to your body or away from your body. Flouroscopy is an x-ray machine. So we bring the x-ray machine right in and look at your hip because of the special table. So we should be able to get the leg lengths nearly exact to the millimeter, and the offset, meaning from the pelvis to the outside of the hip, nearly exact to the millimeter as well, because we're doing it looking at the hip and with x-ray. Whereas the anterior lateral or posterior, we're just doing it from clinical. We're looking at it and getting it as close as we can. We can also do this for fractures. So if this person had a hip fracture and we wanted to do a replacement for the fracture, we can do it on this table. So why not? Why sometimes don't some doctors use it or some hospitals do it? It's a really expensive table. So once you have it, it's good, but it's hard to get it budgeted. So if you go to a hospital and you want your doctor to do an anterior hip and they don't have the table, that may be the reason. Setup time is a little longer. You need someone to run the table. So in the first couple cases, the rep will come and he'll run the table for us. But then once he gets his check, we never see him again. So then we have to teach somebody from our program or from the hospital's program how to run the table. So an extra person to do that. You don't really have a feel for the hip when we're trialing. When we take the fake implants and put them in to see how they fit before we put the real implants in, we're taking your leg when we're not using a special table and we're manipulating it all around, lifting it up, pulling it, pushing it, make sure it's as stable as we can get it so that you do not dislocate. Because if you dislocate, then you got to come to the ER and we got to pop it back in. You can't really feel that on the table, but that's what the x-ray machine's for. The x-ray machine shows us all of that to make up the difference. And then you can perform the surgery wherever they have the table, so that makes it easy once we do get the table. So I think personally, once we get the table, it's actually cost effective because there's all these different things we've learned how to do on it now. So we can do the total hip, we can fix your femur, we can fix your tibia, we can fix your hip fracture. If you were before all this and you need a hip arthroscopy, we could actually do that on the same table now, which is really nice. So what are the indications and contraindications if you need a hip replacement? So if you have end-stage hip arthritis, meaning it's bone on bone, the x-rays show collapse, or the MRI shows avascular necrosis, meaning the ball is dead. You have groin pain or groin pain and lateral pain. You can't walk, you can't put weight on it, you can't internally, externally rotate. It's time for hip replacement. And it's a big surgery. If any of you guys in this audience have had one already? Not yet, huh? Okay. So it's a big surgery. You're in the hospital for a couple days. It's about a 2-month rehab. And you lose some blood. You're under anesthesia for an hour and a half. So it is a big decision. If you have a femoral neck fracture, and that's what this is showing right here, in an active person with a displaced neck fracture with arthritis right here in this area, we take the ball out and then we put a total hip in. And that could be done on the anterior approach with that table or a regular approach. And then obviously if there's no histories of DVTs, no chronic use of Coumadin or Xarelto, if you're on blood thinners, it's a big surgery. We have to wait until we get you off those blood thinners, switch you to Lovenox, and then stop the Lovenox the day before, and then we can do the surgery. So we'll talk about all that at the time of hospital or time of surgery. So this is what we do. We make our little anterior incision, and we put this little plastic ring in there, and that protects your skin. And then we have these metal retractors. These metal retractors have little hands on it by my assistant. And then we're able to see right inside your hip. So you don't need that big lateral incision or big posterior incision anymore. We can do it like this if you're a good candidate. It's obviously less invasive. It's muscle sparing. Your butt muscles, your gluteus maximus and medius, are preserved. We're not back there cutting them or stretching on them. You'll see people come in after a hip replacement and their hip feels great, their groin's awesome, but they have a little limp. And that limp could be because those muscles back there never recuperated from the surgery. We call that a Trendelenburg gait. So we can try a shoe lift, we can try therapy, but some people don't get rid of that limp. They still have a little limp. Your iliotibial band, your big muscle down the side of your leg, is preserved. You have a faster recovery. And the best thing for therapists and Paul and his group is there's no precautions. So when you have an anterior hip approach, as soon as you leave the hospital, you can do whatever you can tolerate. Because of the way the ball goes in and the way the cup and the socket are built, it's nearly impossible, unless you're doing like tricks on the trapeze or ballerina stuff, to get that ball out. Whereas if you cut through the muscle's a little bit weaker and it can't do all the things it used to do, and then there's a chance if you're getting down to get your ball out of the hole playing golf, or if you're pivoting the wrong way and going down to get something off the floor, you can pop that ball out. So that is one of the advantages. It's called the Smith-Peterson Approach. The approach has been around for years and years and years, and it's muscle sparing. These are the muscles that we go through but don't cut. And then there's an artery and two veins that we ligate or we tie off so that it doesn't bleed, and those go to the ball. Since we're replacing the ball anyway, you don't need those. So they're extra once we take the ball out. We do cut the capsule, and then we cut the neck of the femur and the head off and put the new metal one in. So there's a little bit of cutting, but not as much as the other way. So we call it the direct anterior total hip approach, and there's a lot of data and studies out for the last 10 years now. So it's getting more and more widely used, but it's still not the gold standard. So Masonis had a nice study in the Northeast. It was a prospective study, meaning he did it right from the beginning. He said, all right, we're going to look at this, and then they did the patients and did the study. They didn't do the patients and then come back and do the study afterwards. That would be called a retrospective study. So the average age was 59, but he did them as young as 17 and as old as 91. So if you're 91, you have hip arthritis, but you have good bone, you can still get an anterior approach. BMI, meaning the weight that you carry to your body habitus, was 29 average. 16 to 58. Now with the new Medicare studies and with our outcomes at FOI, we try and keep it under 40. So if you're over 40 BMI, we want you to get under 40, where we want to see that you have at least about a 10% weight loss going in, so that we know that it's going to be a little safer for you. Infection rates higher, your dislocation rates higher, the length of surgery is higher for the higher BMIs. So we try and keep it under 40. Patients are immediate weight bearing. There's no toe touch, no lifting your leg in the air with a walker. You're immediate weight bearing with a walker or crutches or a cane. You don't have to protect it at all. There's no hip precautions. You can do whatever you can tolerate. As soon as the pain feels good enough, you can drive. You can take your car, your golf cart, whatever you want. They had 3 groups. The operative time decreased from each group. So the first group was about 2 hours and 10 minutes. Then the second group was 99 minutes. So the learning curve was getting less and less. The third group was 74. So a standard total hip is about an hour to an hour and a half. So now they have the anterior approach down with the first 300 back down to about an hour and 10 minutes. So in summary, the anterior total hip is safe. There's rare instability or dislocations. The alignment is better with the fluoroscopy. The learning curve better with time, obviously. And the patients and the therapists are much happier. And this is pretty cool. I found this little bottle online. It's a little bottle of wine with Infante on it. I haven't tried it yet, but I found it. Hopefully after, right. And then this is what it looks like. So this is the cup. This is the neck. And this is the stem. And then the ball is inside of the cup. And that's us doing the special table. And then this is how they do it on the regular table. It's pretty similar, only you have all of these assistants with you. This is the little stem going in. You see how it's got a little hook to it? So it comes in and it slides up the femur. And that's so that we don't go straight down and through the femur. If we go straight down and through the femur, then we have to take that out and cable it, and then we don't let you guys waver on it. So ideally we don't do that. It can happen, but we try not to. Then this is what the ball looks like right before we pop it in. And this is the final product. So cup, screw, ball, stem, and that's a complete hip replacement. And then you can get up. If you do it early enough in the morning or up to about 1 o'clock, you can get up that same day with therapy and walk. If it's later in the day, like 4 or 5 o'clock, then we get you up the next day. So weight bearing immediately, no precautions. 1 to 3 days in the hospital instead of 3 to 5 days. If you wake up the next morning and your blood work is good and you walk with therapy and you want to go home, you can go home the next day now. Depends on if you have somebody at home with you, if you make sure you can get around, you can get up from your chair to your bed, to your kitchen and your bathroom, you're ready to roll. So we can use the special table or the regular OR table. We prefer the special table. The patients, the therapists, and the nurses are all very happy without the hip precautions. Nowadays, actually, if I do a regular hip replacement, then Paul from therapy or Heather from therapy will call me up and give me crap of why I did it. And I actually have to explain to them why I did it. It's kind of like having an extra wife. So we try to do anterior approach if we can. All right, so hip fractures. As we get older and older and older, we're going to fall and we're going to get hip fractures. Or some people think that we get hip fractures and then fall. So if you have osteoporosis or osteopenia and you're walking and you have a stress area in your femur, it can crack and you can fall. So we'll see people in the hospital and they say, "Doc, I was walking fine. I swear this broke before I hit the ground." And it's very possible. It happens a lot. And it can happen in different areas. It can happen in the subcapital, which is right below the ball. It can happen in mid-neck, where this one is. Or it can happen down here in the trochanteric region, which is intertrochanteric. And there's different things that we do for those hip fractures, and most of those things are new nowadays in the last 10 years. Those are different types of hip fractures. There are no tests. You don't have to learn those. So femoral neck, it's intracapsular, meaning the blood supply is cut off. So we either have to fix those right away, or we have to replace them if you have arthritis. This is the different areas and the different angles that they happen. And these are all the different ones that we've seen. If it's down low like this, we typically fix this with a rod and with screws. If it's this area in the intertrochanteric region, again, it gets a rod and screws. This one is more stable, so the rod is short. This one is unstable, so the rod is long. If you get to the ER and you have groin pain or thigh pain and you can't walk like you used to, you tell them you think you broke your hip. It's not coming from anywhere else. They do all these other tests and then they send you home. And then when you're home, that hip fracture can get worse. It can move and it can displace, and then you can't walk at all. And then we have to do a bigger surgery. So I try to teach them it's not a zebra, it's going to be a horse if you hear hooves. Always think hip fracture in this population. If it's not a hip fracture, fine, but you got to get a CAT scan, you got to get an MRI, you got to make sure it's not a hip fracture. Don't send them home. So we get the x-rays, we don't see anything. We say, okay, something weird is going on. They have groin pain, they don't feel right. We get the MRI. Boom, big crack right through the neck. The MRI is so much more sensitive nowadays than an x-ray, so we have to check that in the ER for you. We can get a CT scan if you have stents, if you have a pacemaker, if you have some metal fragments in your head and you're afraid the MRI is going to pull those metal fragments out, or your eyes, then we can get a CT scan. The CT scan isn't as good as the MRI. The MRI is the most sensitive and you see the cracks really well. This is what we see in the ER if you break it. And then we give you some sedation and we pull traction on it to see what it's going to look like when it lines up. Sometimes we do this in the OR if you guys are already on the floor. We don't like to pull on your broken femur if we don't have to while you're awake. Physical exam. So if you come to the ER, you see this at home, your one leg is up with a little bit of rotation, and your other leg is out with a lot of external rotation, that's a hip fracture until somebody else tells you differently, okay? So either get a ride to the hospital or call 911 and get there, because when you externally rotate like this, the ball and the femur aren't intact anymore. So what to do? We can reduce it and fix it if we get it quick enough, or if it's non-displaced. If it's displaced and have arthritis, we can actually do a hip replacement just like we talked about before. Totals can be the anterior approach just like we talked about. And if it's your right leg, you're driving almost immediately with an anterior approach. 4 weeks typically for the posterior or the anterior lateral approach. So you save about 4 weeks of driving time, especially if you live alone. And we remember that as we get older and older and you get into your 80s, you can't really hop. It's really hard to hop as an octogenarian. So kids can hop, the octogenarians can't. So we try to fix everything and make you weight bearing. If you're trying to hop and you're trying to use a walker, chances are you're going to fall again and you're going to break something else or you're going to hurt your head. And if you're on blood thinners, Coumadin or Lovenox or Xarelto, then something's going to bleed. So we try not to do this. If somebody tells you, oh no, you're non-weight bearing on that, question it. Say, why am I not weight bearing? Who said I'm not weight bearing? Maybe the order is incorrect. You should be weight bearing on all of these. Thank you very much.